Good afternoon, everyone. My name is Ashley Wilson, and I'm a part of the NIHR Research Support Service delivered by Newcastle University and Partners, who lead the RSS Capacity Development Working Group nationally, and as part of that, run this seminar series. So I'm really pleased today to be included within this session and led by colleagues Paula Williamson, who is a professor of biostatistics at Liverpool University, and also Dr. Lisa Fox, who is the Assistant Operations Director at the Institute of Cancer Research, and Jessica Griffiths, who's also on the call, who is Sustainability Project Manager at the Institute of Cancer Research. So I will shortly hand over to Paula. But as a reminder to people that have attended the seminar series before, and also for new people, we record and transcribe these sessions. So the idea is that we'll follow the session up with the slides shared by those presenting. And there's also an opportunity at the end of the presentation to ask questions from colleagues too. So we'll probably wrap up shortly before 1 o'clock. Thank you. Thanks, Paula.
Thank you very much for that. Lisa's kindly sharing the slides from her side. We are, in fact, a triple act for you today, as Ashley's told you about. So you can see on the slide that it really is a team effort. There'll also be some work presented around the involvement of our colleagues from the University of Aberdeen. Next slide, please, Lisa. What are we talking about today? So introduction to the climate crisis, specifically looking at healthcare and health research, but then moving on to focus more around clinical trials. What's going on? What's the current landscape around looking at lower carbon clinical trials? What do we know about the carbon footprint of publicly funded clinical trials? And importantly, what mitigation strategies should we be thinking about now? Next slide, please. So, when you think about and look at environmental impact, it is more than climate change. It does include biodiversity loss, pollution and water scarcity and other impacts. Most of what has been done to date, not all, but most current research around greener trials, and by that I mean trials where we are trying to lower the environmental impact, most of that research does focus on climate change. So climate change is where there's an imbalance between energy absorbed and energy emitted by the Earth. And I'm sure we're all aware of the term greenhouse gases. These are greenhouse gases that are emitted into the atmosphere, and they are trapped and they can cause warming. Next, please. Next. Okay, so you will again all be familiar with things happening around the world that are related to climate change, extreme heat, variation in normal weather patterns, variations in snow, rain, etc. And I think that we are increasingly conscious of the need, the impact of humans and the need for humans to do things to try to mitigate and reduce further impact of climate change. Next slide, please. When people in clinical trials and healthcare research talk about the impact, the environmental impact in relation to climate change, we talk about carbon footprints of our activity. So a carbon footprint, despite it having the word carbon in it, it's actually a measure of the greenhouse gases that a particular activity results in that is being released into the atmosphere. So we talk about the impact in terms of carbon dioxide equivalent emissions, so CO2e. And just to put some numbers that you'll see a bit later from Jess on the screen, just to put those numbers into context, the estimate for the year 2021 in the UK was a total carbon footprint of 341.5 million tonnes of carbon dioxide. And looking at the population at the time, that would result in a typical UK citizen, through their activities, would be responsible for emitting 12.7 tonnes of carbon dioxide, or carbon dioxide equivalent. So remember that sort of 12 to 13. Of course, these numbers do change, and they change because our knowledge of the emission factors associated with particular activities does change. Some things become more accurate. Sometimes the type of activities change. Next slide, please, Lisa. So if we now look at healthcare and healthcare's carbon footprint, if you take the total estimated emissions across the world associated with healthcare, the total emission across the world is 2.5 billion tonnes carbon dioxide emissions per year. Healthcare is responsible for around 5% of that. There was a piece of work where it was estimated that 4,500 tonnes of carbon dioxide emissions would equate to one global excess death, so that climate change caused by this amount of emission of carbon dioxide emissions was causing excess deaths. And per year, the amount of emissions created through healthcare would then cause 600,000 excess deaths a year. Next slide, please. So clearly there is a need to look at where hotspots of carbon emissions are occurring in healthcare systems. This is a great paper from people working in the GIRF, that's Getting It Right First Time team, with the NHS Greener team. So they looked at, over 1 year, the carbon dioxide emissions from estimated from activities recorded through HARES and other routine sources of information, and they took the total healthcare emissions. These figures here are split by specialty area, and they are in kilotons of carbon dioxide emissions, but you can see where the hotspots are in terms of the areas of healthcare. And so within our work, and I'll talk about it in a minute, we're moving on to looking at clinical trials within the healthcare system. And we're really interested in looking at clinical trials in those areas that already have a high emission, a high carbon footprint. Next slide, please. So people are looking at the environmental impact of healthcare interventions. There was a review last year, no, 2 years ago now, 2024, that reviewed studies that had reported, had looked at the environmental impact of healthcare interventions, but they found that the design of those studies was of poor quality. So many of them were observational, they varied in terms of their greenhouse gas measurement, and they varied in terms of the health outcomes that were also being examined. The UKRI and NIHR have invested recently in what are referred to as sustainable health systems hubs. Lisa, Jess and I are involved in one that's led from Exeter, and together with the GIRF team, we are looking to develop a framework for deciding, when you have a mitigation strategy to bring into healthcare, can that strategy be implemented immediately? So is it obvious that a change that you can make in a care pathway or a healthcare intervention, it's so obvious that it will have a lower environmental impact with no adverse consequences for patients that it should be implemented immediately? Or is the level of uncertainty such that you feel it can be implemented, but you need to monitor patient health outcomes? Or perhaps the level of uncertainty is so great that it should not be implemented before further research to check the balance of trade-offs between environmental impacts and health outcomes and cost. Perhaps that research should be undertaken first, and that research might be through randomised controlled trials. A colleague from Glasgow, Beatrice Goulau, looked at trial protocols last year and found that across the board of protocols and trial reports, she only found 16 that made some mention of assessing the environmental impact of the healthcare interventions in those trials. And in fact, 9 of them were in the last 3 years. There is more work now being done. There are more trial protocols that are looking to assess environmental impacts. And indeed, in response to that and the climate crisis, there is now work in progress to develop spirit and consort extensions that are for when you are running a randomized controlled trial and you want to assess the environmental outcomes associated with the healthcare interventions that you are evaluating in that trial. This is about getting some standard reporting guidance in place. Next slide, please. So a couple of years ago, the Academy of Medical Sciences brought together people working in biomedical research to actually look at the environmental sustainability of research. So in terms of what we do as part of our research processes. And it was quite clear from that workshop that there was great work being done in laboratory research, but not a lot in clinical research and clinical trials. Slide, please. Of course, at the time, there was great guidance from the NIHR in terms of their carbon reduction guidelines. There's also various guidance around procurement and supplier sustainability practices. And obviously, I think many of us here on the call will know that we absolutely need to avoid research waste. We've known that for many years, but it is increasingly important when you think about it with an environmental lens as well. We cannot afford to be doing research that will have an environmental impact that is not relevant, does not lead to rigorous, valid results at the end. Next slide, please. Moving things on, the Academy also ran an international project between the UK and the US, looking at policy recommendations around environmental sustainability of health research. And I would recommend that you take a look at this because it does show where some policymakers are bringing in recommendations and guidance for researchers, be it they might be funders, they might be regulators. So that's definitely worth a look. Things have moved on a little in the last couple of years. Next slide, please. A colleague, Frank Yu, up in Aberdeen, undertook a review of clinical where carbon footprints of clinical trials had been estimated. He found 22 studies. They varied in all sorts of ways, but in particular, they varied in terms of what was being footprinted in the clinical trial that was the focus of the study. Scope of footprinting is really important, and I know that both Lisa and Jess will come on to that after me. Next slide, please. I think at this point I am indeed passing over to my colleague Lisa. Thank you.
Thanks, Paula. As Paula said, the next kind of section of the trial is thinking with a little bit more focus, particularly on clinical trials and the environmental impact of the research itself. So when we're thinking about enabling lower carbon clinical trials, we just thought maybe helpful to go through the current landscape and the jigsaw of actors and the work that we know that we're aware of that's ongoing in each of these jigsaw puzzles. So as we all know, clinical trials, their delivery and design is a cross-sector endeavour. So if we want to make any changes to clinical trials to enable them to be lower carbon design, we really need to do that together, thinking about the kind of complex jigsaw of actors that come together to deliver a trial. So I'm going to take each one of these pieces in turn, tell you a little bit about what we know of the work underway and how we as public sector academic trialists are trying to collaborate to bring our work together to align it as much as possible across the sector. So starting with us as academic clinical trialists working on publicly funded UK clinical trials, obviously clinical trials are crucial to the development of new treatments and the advancement of medical knowledge. But as Paula said, they have an environmental impact and contribute to those healthcare emissions that Paula mentioned. Current estimates are kind of rough and broad, but somewhere in the region of 30 to 100 million tonnes of CO2 equivalent emitted per year. So when we're thinking about a carbon footprint and how to reduce it, perhaps the first step is to consider how we best quantify it. And Paula, Jess and I were involved in the development of a method and guidance to quantify the carbon footprint of publicly funded trials. The top paper here is the publication of that method and guidance and piloting it on 2 initial trials. But importantly, within the appendices and supplementary materials are all of the resources and tools and information and technical guidance that we used in order to do that footprinting. So anybody could take those resources and footprint their trial. The intention of our tools and their kind of target audience is for academic publicly funded trialists. You don't need any prior experience of carbon footprinting or environmental impact assessment to use them. You can use our tools at any stage of a trial, at the concept development, once a trial is in progress or once a trial is completed. And all of the resources and tools are open access, free to use, and we also provide monthly training, which is also open access and free to attend. Jess will tell you a little bit more about those monthly drop-in clinics. The idea of those clinics is kind of multiple fold. It's to raise awareness, train our community in the idea of carbon footprinting, but also not just as a kind of ideal, but when teams want to apply it to a real life clinical trial, we'll kind of continue to provide support. That's really beneficial to us because by footprinting new trials with new activities that we haven't footprinted before, it allows us to refine and expand the guidance to make it more broadly applicable. And it also allows us to communicate with the teams doing this, collating that data on the carbon footprint of the trials they're footprinting. The second paper here, again, Jess will talk in more detail about the results that we found. We've published the results from using our guidance on 10 more UK CRC CTU registered clinical trials. It's a small data set that we've published, although it's growing by the day. I guess the key message to kind of mention now is that there are some trends emerging in terms of where we see the hotspots or the greatest contributors to the carbon footprint of a clinical trial, but we still see a big variation in where those hotspots are, depending on kind of size or phase or kind of extent of participation or duration or disease area or intervention. The take-home message for us is that we need to consider trials on a case-by-case basis at the moment, and we need more data. We need more data and we need to grow our evidence base to be able to draw the conclusions that we need in terms of where those hotspots will lie. And I suppose kind of another important message for those teams wishing to incorporate the consideration of a carbon footprint of their trial, if kind of a barrier or a limitation is that teams don't have time to do this, we've also written a template SWOT, which is now added to the Northern Ireland Hub for Trials Methodology Research SWOT repository. So this is just a template SWOT for those who may wish to incorporate this into funding applications, but haven't had prior experience of this. Hopefully this is a useful tool and reference of how this could be incorporated as a SWOT in new funding applications for clinical trials. It gives an idea of possible objectives, aims, and kind of FTE of teams or trial team staff that could be included in that SWOT to support this type of activity and consideration of the carbon footprint of a trial at this crucial design stage. So we're very much just at the beginning of this work. As I said, our data set is small. There's a huge amount that we want to do and are doing at the moment. We have a huge ongoing programme of work, and we're really excited and pleased to have that work supported by Welcome and the UKRI grant that Paula mentioned earlier. Just to kind of give a brief overview on the work that is underway. As I said, it's crucial that we collate more data on the carbon footprint of publicly funded trials, and to facilitate that, Welcome are funding the development of the Greener Trials Toolkit, which is a free, online, automated, open science, fully referenced toolkit for our publicly funded trialist community with multiple functions. So that toolkit will have an online carbon calculator, which we hope will speed up and simplify the actual calculations themselves. It'll also kind of, once it gives the result of a carbon footprint of the trial, will also provide linked guidance on how to reduce the hotspots that have been identified. But also the toolkit will include a database of the emission factors and the kind of technical documentation and calculations that we are using in our toolkit. We want to make that publicly available so that those can be improved upon, shared and critiqued and refined and expanded as we go. But also we will ask all users using the toolkit to calculate carbon footprint of a clinical trial, whether they'd be willing to share their results with the toolkit to kind of build that evidence base that we talked about, so that increasing evidence base and collation of data will be overseen by the required governance structures and committees, but basically to make that data available to our community to do the research that we need to do to enable lower carbon clinical trials. So there's a huge kind of work stream about collecting more data, supporting trialists to do that footprinting and do as much dissemination and engagement as we can. Paula and the University of Liverpool team lead work stream 2, which is all about analysing that accumulating data and evidence base to identify hotspots. To then look at those hotspots, develop, identify, appraise and share the mitigation strategies that will inform lower carbon trial design. Collaborators at the University of Aberdeen are leading work stream 3, which is looking at the application of behavioural science to support engagement and involvement of the relevant parties in greener trials. So thinking across that jigsaw piece, puzzle piece, what are the enablers, the barriers for each of those groups, so that we really can support engagement in this. It's crucial, as we've said, that we move forward together. So via the Wellcome and UKRI grants, we are also working with the pharmaceutical industry, the NHS, international collaborators, funders, and patients and the public. And I'll just take each of those in turn now to talk briefly about the work that we know is ongoing in each of those sectors and how we are trying to collaborate. So starting with the pharmaceutical industry, it's fantastic to see pharma companies now publishing results of carbon footprint of their trials. But what's even more exciting is companies are not working in isolation, but have been convened by initiatives such as the Sustainable Markets Initiative and organisations such as the Sustainable Healthcare Coalition into the Industry Low Carbon Clinical Trials Group. And we, Paula, Jess and myself, are on that group representing academia. And together as a collaboration, we've developed a common methodology framework for assessing the environmental impact of clinical trials. And under that framework sits a guidance document and online carbon calculator pointed towards industry trials, and our guidance document and the Greener Trials Toolkit, which is specifically focused towards publicly funded trialists. The initiative and the industry group is fantastic. There's a huge amount of work underway there. Companies have pledged to report the carbon footprint of their phase 3 trials from this year. There's a number of proactive action groups looking at various different areas of integration, of data, of reporting, and a community of practice, bringing everyone together and linking across the academic community. So a huge amount of work ongoing, and we across our guidance documents and tools from a technical point of view are seeking opportunities to kind of align everything that we do so that the tools meet the requirements of both parts of the sector but are aligned as much as possible. In terms of healthcare systems and health research policy, fantastic that the NHS were the first healthcare system globally to set a net zero target. The NHS aim to be net zero by 2040 for the emissions they control directly and 2045 for the emissions they influence. And there's an incredible amount of work underway via the Greener NHS, both in kind of direct activities and looking at the NHS supply chain to decarbonise all of that. Paula mentioned the Getting It Right First Time team, who look at the kind of ideal care pathway and look for kind of to mitigate against geographical variation in that for clinical outcomes, but now with a new lens of environmental consideration of those care pathways. And via the UKRI One Health Systems Net Zero Hub that we're part of, we're working closely with the Getting It Right First Time team to align the footprinting of clinical trials being run within those health systems and the NHS with the carbon footprinting of the routine care pathways and interventions that's underway. I won't spend too long talking about the health research policy elements. Paula's touched on that briefly, but I think the groundswell of interest and work in the last couple of years in this area really has been supported and encouraged and facilitated by those policymakers. So clinical trials are closely regulated, as we all know. So what is ongoing in terms of the regulators, competent authorities and ethics committees I think perhaps regulators won't set regulatory requirements in terms of consideration of environmental impact, but they definitely are included in the discussions and keen to ensure that what we consider and suggest is compliant and in line with regulatory requirements, and that regulations don't become a barrier to this. So here on the right are a number of organisations, reports and conferences which are facilitating the ongoing discussion with regulators, which is really encouraging. But it's also really good to flag and highlight that the Declaration of Helsinki actually already includes Principle 11, which states that medical research should be conducted in a manner that minimises possible harm to the environment. And there's a number of papers and reviews reviewing the current landscape and making suggestions as to how we may move this conversation forward. So a review stating that actually, as a community, we're neglecting to consider this in the design of research, and that neither ethics committees or regulators are considering this or assessing this currently. If we were thinking about where this could be considered, there's another paper suggesting that perhaps ethics committees would be best placed to do this as the organisation already considering the risk-benefit ratio of a trial. And coming back to the idea that Paula was mentioning about incorporating the environmental impact assessment of interventions into clinical trials, other papers suggesting how this could be incorporated as secondary endpoints so that regulators and policymakers, when reviewing the results of clinical trials and that clinical data, would also have environmental impact data to assess alongside. In terms of public funders of UK research and innovation, perhaps the current thinking is best exemplified by the Concordat for the Environmental Sustainability of Research and Innovation Practice. A bit of a mouthful, but the UK research and innovation sector have come together to develop this voluntary environmental sustainability concordat. So higher education institutions and funders are invited to become signatories, and then once signatories, they pledge to look at their environment, the research that they support through these 6 key pillars, including leadership and system change, infrastructure, procurement, travel, collaborations and partnerships, and importantly, this last one, number 6, considering the environmental impact and reporting data. So any signatory to the Concordat is pledging to be able to report on the environmental impact of the research that it funds. And a number of the biggest funders of UK clinical trials are signatories to this Concordat. So taking the examples at the bottom here, Cancer Research UK have signed up to the signatory, and they are the first funder that we're aware of, there may be others now, who ask trialists at the time of application whether they've considered the environmental impact of the trial that they are submitting. Wellcome ask for LEAF accreditation and all the laboratory research that they fund. And then the NIHR, although they don't ask at the time of application yet, they are asking in progress reports and final reports about how teams have considered the impact of the research. The voice of patients and public is crucial in this discussion if we're going to change the design of trials or the way that data is collected with a view of making trials more environmentally friendly. We on the Wellcome and UKRI grants have patient participation within the team and on steering committees, and I think incorporation of the patient voice is crucial. Paula mentioned that the workstream 3 led by University of Aberdeen, looking at the behavioural considerations and aspects of this, and there are a number of focus groups running as part of that workstream, inviting patients to give their views on the idea of greener trials. And we've been involved in the development of an animation introducing the idea of greener trials that we developed with patients for patients to help facilitate that conversation. So if you are starting in this and want an easy and accessible resource, perhaps that might be a nice place to start. And finally, just with the view of moving forward together, if anyone is interested in more information or joining the community and sharing your ideas, the TMRP have convened a Greener Trials group with national and international involvement from the trialist community from all professional backgrounds, so trialists, methodologists, health economists, policymakers, funders, regulators, patients, etc. Anyone who's interested in this area and would like to join a group. We meet every other month, hear from members on the work that they're conducting in this area, and we hope it's an open forum for the dissemination and promotion of this, setting the research agenda, sharing opportunities for collaboration and funding, etc. So if you're interested in getting involved and finding out more, just drop me an email. And I'll stop there and pass over to Jess for the next section.
Thanks very much, Lisa. So yeah, I'm going to talk a bit more about what is the carbon footprint of publicly funded clinical trials. So as Lisa mentioned, we developed a guidance and method document to calculate the carbon footprint of publicly funded trials, and we piloted that onto ICR CTSU trials, the process and results of which we wrote up in the BMJ open publication linked on this slide. So the detailed guidance that we developed defines the project scope, the limitations, the assumptions, as well as the detailed breakdown of all of the calculations required to calculate the carbon footprint of each of the activities that we've defined as within scope. So the most up-to-date version, as Lisa mentioned, these documents were kind of published as part of that BMJ open publication, but I just wanted to mention that the most up-to-date version of these documents is kept on the TMRP Greener Trials webpage, which can be accessed via the QR code that's on this slide. Next slide, please. So in terms of the development of the guidance, we started by mapping out all of the activities that take place in a typical clinical trial. So we met with all of our collaborating CTUs to get their perspectives and understand their trial portfolios, and developed a process map that defined our scope. And then we built an emission factor library around those activities that we identified. So within the guidance that we went on to develop, we grouped those activities in the process map into 10 different modules. So we've got trial setup, sponsor emissions, which relates to CTU staff working in an office and commuting or working from home. Trial-specific meetings and travel, intervention, trial supplies and equipment, trial-specific patient assessments, samples, lab, data collection, exchange, and trial closeout. So to actually calculate the carbon footprint of each of those activities, activity data must be collected and multiplied by a corresponding emission factor. So in the context of a clinical trial, activity data could be the kilowatt hours of electricity used by CTU staff in an office, or kilometres travelled by a trial manager for a monitoring visit, or kilograms of plastic in a sample kit. And an emission factor is a coefficient which allows you to convert that activity data into greenhouse gas emissions. So an example calculation on the slide is road freight. So in this case, the activity data that you would need to collect in this example is the mass of the shipment in tonnes and the distance that it travels in kilometres. And this is then multiplied by an emission factor to produce a carbon footprint. Next slide, please. So to further test the method, we worked with 10 clinical trial units in the UK and also internationally to carbon footprint trials with a variety of interventions. So these interventions range from IMP trials in breast cancer, gestational diabetes, stroke, HIV, and COVID-19. We also looked at a surgical trial, a nutritional supplement trial, a behavioural complex intervention trial based at schools, and also a health surveillance trial in dental recall strategies. The trials had both national and international reach, so 7 were conducted within the UK only, 2 within the Republic of Ireland, and 1 was an international trial with participation from 10 countries and regional trial management and sponsor CTU based in Australia. So to carbon footprint those trials, we worked with a variety of people, including clinical trial managers, MSc students and PhD students. The time taken ranged for the teams to carbon footprint these trials range from 5 to 60 hours, but this really depends on the complexity of the trial and how familiar the person doing the carbon footprinting is with the trial itself. So in the case of 5 hours, this was a single site study with 100 participants, and the person doing the carbon calculations happened to be the research nurse and also trial manager on the trial, so the information was readily available. Whereas in the case of 60 hours, this was a MSc student who wasn't involved in the conduct and design of the trial. Therefore, it required quite a few data information gathering meetings with the trial team, as well as the calculation themselves, and it was a much bigger trial. But CTUs who have footprinted more than one trial have noted that much less time is required to footprint a trial the second time. Next slide, please. So on this slide are 12 pie charts, which show the footprint of the 10 trials in the test phase, as well as the 2 pilot trials, and the contribution from each module. So each module is a different coloured segment. I know there's quite a lot going on this slide, so I thought I would just pick out kind of the overall key takeaways and some of the hotspots. So the estimated trial footprints range from 16 tonnes in on-pace, which is on the top left-hand side of the slide, to 765 tonnes in Interact 3, which is in the top right-hand side of the slide. So On Pace was a single-site study, as I said, with 100 participants, whereas Interact 3 was the international trial which recruited 7,000 participants across 122 sites across 10 countries. You might be able to see that in almost every trial, the orange section, which is CTU emissions, was one of the largest contributors to the trial footprint. So I think it was one of the top 3 contributors in 11 out of 12 of the trials on this slide. So as I said, this is CTU emissions, and this relates to energy consumption of trial staff working in an office and commuting or working from home. And we found that generally CTU emissions increases as FTE increases, with increased number of sites and participants and a longer trial duration. The dark blue segment, which is trial-specific patient assessments, was also a hotspot in a number of the trials, and we found that generally patient travel to study visits that were in addition to standard of care was frequently the largest contributor to this footprint. Where samples were collected in a trial, we found that laboratory, which is the dark grey segment, was often a hotspot due to either international shipment of samples or sample kits, or storage of samples in ULT freezers for up to 10 years. And then in addition to those kind of more frequently seen hotspots that I just mentioned, we also found that there were hotspots more specific to the trial design itself. For example, in HEAL COVID, which is at the bottom left-hand side of the slide, we found that data collection and exchange was a hotspot due to the considerable cost attributed to accessing and linking data from NHS England and purchase of software to operationalise the decentralised trial design. However, we did use a cost-based emission factor for these activities. Therefore, we do disclaim that this could be an overestimation and are working on a more activity-based approach for this. And then in Emerge and the UK Stand Together trial, trial supplies and equipment, which is the green segment, was a hotspot due to provision of glucometers and tablets, respectively. So overall, as you can see that across different interventions, number of sites and participants, the hotspots do vary. They don't all have exactly the same 3 hotspots. This demonstrates why we need to collect more data, particularly when we're starting to consider ways to reduce the carbon footprint of our trials. Next slide, please. So to support clinical trial units or those interested to carbon footprint their trials and collect more data, we run monthly carbon footprinting drop-in clinics. The first hour of the clinics is an introduction to carbon footprinting and how to use the resources that we've developed. And then the second hour is for those with specific carbon footprinting queries to drop in for one-to-one support. So as Lisa said, more data is needed. The more trials that are footprinted, the more robust the guidance will become as more activities and corresponding emission factors are characterised. And this continued improvement will increase applicability to a wider variety of trials, enable us to speed up the data collection for future users and inform carbon reduction strategies. So if you'd be interested in joining a drop-in clinic, do feel free to get in touch via the email address on this slide or by Lisa or I. Next slide, please. And I won't talk too much about mitigation strategies, but some of the things that we do say that trialists could do now. There is guidance available, as Paula mentioned. There's the NIHR carbon reduction guidelines. There's also the UK TMN Guide to Efficient Trial Management, which has a sustainability chapter, and UK CRC Greener Monitoring Guide. You can encourage suppliers, vendors and third parties that you work with to consider sustainable research practices. In terms of trial design, as I just mentioned, there's clearly some hotspots that we can begin to consider and potential mitigation strategies, which Paula is going to cover on the next few slides. And finally, as Lisa touched on, get involved with country-specific but collaborative networks to share knowledge, such as the R&D Sustainability Forum and the Greener Trials Group. I think that's all for me, and I'm handing back to Paula now.
Thanks very much. So I'm just going to finish off with some of our thoughts on mitigation strategies for these 4 sort of common hotspots that were shown on the pie charts that Jess was describing. Next slide, please. I'm going in reverse order. So, you know, we are absolutely aware that laboratories have been doing a lot of work about reducing their environmental footprint for a while, and there are different lab accreditation schemes, but for clinical trialists, obviously, you know, they can look at whether the labs that they're working with do have LEAF or My Green Lab accreditation. Similarly, you know, CTUs are within an organisation, and looking at the procurement practices for the organisation as a whole in terms of the suppliers and vendors is an important thing to consider. From a trial design point of view, it's always the case that you should be looking at relevant time points for sample collection. Are you actually going to analyse all of the data from all samples taken at all time points, and similarly looking at efficient shipment conditions? Jess has already mentioned the freezer issues. I won't go into that, but I know we are aware that there's a good deal of work going on amongst our commercial colleagues in the pharmaceutical companies, looking at ways to be more efficient in terms of shipment of the IMP and supplies. Next slide, please. I think we're probably all much more used to now about running trial meetings online and webinars such as this online. There has been an increase in those site setup meetings and the site training that can happen online. There's an acceptability of that from the regulators. For particular trials, we run our oversight meetings online now, and many site monitoring visits, or some site monitoring visits, it is possible to do them online. I know there are questions about if you're using healthcare systems data, what the approach to monitoring those data are, but generally there are examples of where clinical trial sites have been monitored through an online mode. Next slide, please. Okay, so Jess showed that the dark blue in those pie charts, trial-specific patient assessments, and that comes from a calculation based on travel, the number of visits, both screening, the eligibility assessments, but it also outcome assessments. Those of you that know me know I can't possibly do a talk without mentioning core outcome sets. So it comes back to the idea of research waste. So in and of themselves, measuring core outcome sets is not going to reduce the carbon footprint of a trial, but if you do a trial that does not produce evidence around outcomes that matter to decision makers, you're contributing to the carbon footprint of healthcare research without actually contributing to knowledge. The other issue around data, and this is where Jess touched on, so we are looking at greater a better estimation around data linkage and transfer. But of course, there is also, when it comes to the sample analysis for outcome, there is also a question about looking at whether or not you need to use a central laboratory, perhaps because they have specialist techniques for sure, but actually is there local capacity that can produce analyses of sufficient quality. Next slide, please. We can move on from that. I've mentioned that, Lisa. Next slide, please. Okay, so the common hotspot, it was orange on the slide, CTU emissions. There are some things that are obvious that you can do. So moving to electronic documents rather than printing. If you are using paper, sustainable paper choices. Also from a computing side, looking at the Green Disc Digital Sustainability Certification and their initiatives. But the majority of that hotspot from CTU emissions comes from the footprint of staff. Obviously, clinical trials unit staff are absolutely vital to running a trial well. The proposal to mitigate is not about changing the trial duration. The follow-up time in any trial, follow-up of patients, should be as required scientifically to answer the question well. But as we all know, recruitment to trials almost always takes longer than you would anticipate. We do need to make sure we are doing as much as we can to reduce the time it takes to recruit patients. Similarly, we don't want to recruit patients and not collect their data, so anything that can be done there as well. Next slide, please. I will whiz through a couple of things. So there is a lot of work going on at the moment around whether digital technology can both improve the efficiency of clinical trials and also lower the environmental impact. We have examples of digital technology in various aspects, various components of a trial. Next slide, please. CTUs in the UK have been using e-consent systems for a while. Nearly 2/3 were using it or had implemented e-consent systems by 2021. It's not without its challenges, and there's a lovely paper led by Eleanor Mitchell and the UK Trial Managers Network that will be on the slides for you. Next slide, please. Similarly, using routinely collected data, healthcare systems data, rather than setting up new systems to collect the same data again, is a way of reducing the environmental impact. But obviously, you need to look carefully at the accuracy, the validity of those data. And again, we can see an increase. So between 2019 and 2022, in NIHR trials published in the protocols, there was an increase in people using healthcare systems data for their trials from 47% to 62%. It's going up, and this does mean that you're reducing the amount of data collection or data being collected twice. Next slide, please. Similarly, patient-reported outcome data, again, between 2019 and 2022, if you drop down to the right-hand side, the online, you will see a big increase in PRO data being collected through web-based systems or a little bit through apps, but predominantly through web-based online systems. Less evidence here about wearables, but this is because this study was about NIHR health technology assessment funded protocols, so the later phase trials. At the moment, you tend to see more outcomes being assessed through wearables, electronic devices in the earlier phase, the sort of NIHR, EMA type studies. Next slide, please. I'm coming to an end. We have to be careful. So the idea that digital technology is going to reduce the environmental impact, there are several reasons why that might not be the case. It might have to do with the technology itself and what you do with that at the end of the trial, but also there is the issue of digital exclusion. We know we must improve our inclusivity. It doesn't mean necessarily that digital technology, it will improve inclusivity for some, but not necessarily for all. You may not improve recruitment, you may, it's not clear. So we do need more research around the use of digital technology and whether it can improve inclusivity and reduce to avoid digital exclusion. Next slide, please. Okay, final short plug, quick plug. This theme of environmental sustainability of clinical trials, it is a theme at the next International Clinical Trials Methodology Conference in Birmingham, September later this year. Next slide, please. It just remains for us three to thank all of our partners and collaborators. You can see them listed on the slide. We hope from the number of people here that you join in and you can get your logo on the slide going forward. Next slide and final slide, a final thank you from us. Thank you very much. We are 12 minutes shy of when we're supposed to stop. If you want to stop sharing, Lisa, we're very happy to take questions. I'm just going to have a look in the chat to see if there are any there, but please feel free to put your hand up, to put your camera on, ask us any questions. Okay, I can see a CL, I think it was. You've got a number one next to your hand. Do you want to?
I think that might
Claire.
be me.
Yes.
Sorry,
Claire,
yeah, I
thanks.
can't see anyone. I can't see who I'm talking to. There was a really important slide of a contact detail and a load of dates.
Okay.
How do we?
Okay.
I can put that in the chat.
Jess is going to put something in the chat, but this is being recorded and the slides will be available and you will be emailed because you've been registered for this. You'll be emailed with that information. But Jess, if you can.
Sorry, we didn't register. We just got a link in our chat. So I'm just conscious that my email isn't anywhere and I didn't register. We just, our unit got a link to the chat, the meeting only.
Jess, could you put the CICT email? There we go. Jess has just put that.
Thank you very much.
All right. Sorry about that, Claire. Thank you. I did see another hand up. It's gone down. It may be the same question. I can see in the chat. Okay. Andy, does data storage for years, Andy Vale, does data storage for years following a trial contribute meaningfully to carbon emissions? So this is an area that we're trying to work on with a colleague from Cambridge, Langalong. He, not green disk, just trying to think of the, remind me, Lisa.
Green algorithms.
Green algorithms, sorry. So he is looking at the computing side of things, but also data storage. I don't know, Jess, did you want to come in and say anything about this? Because obviously whether it's clinical trials or other health research, the amount of data is increasing ever more, and the data storage goes alongside it. Jess?
Yeah, so I think as you touched on, it's I think we're still quite early on in quantifying the carbon footprint of, I guess, electronic waste and data and transfer of data. From the trials that we've footprinted, the storage of that data hasn't contributed a huge amount to the carbon footprint. This could be down to kind of the quantification methods, but I do think I think the estimation is about I need to just check, but I think it's 0.017 kilograms per gigabyte of data. So just for some context, it is quite small. So yeah, not a hotspot that we've seen yet, but I think we also need to keep an eye out for kind of the increasing use of AI, and that also isn't kind of accounting for more data intensive projects that might include imaging or genome sequencing and things like that. So I think it does depend on the specific trial and the activities that you're footprinting, but no, we haven't found it to be a hotspot compared to things like CO2 emissions and patient travel and transport yet.
Thank you for that, Jess. Ashley, I'm just wondering whether you can answer the question. Sorry, I thought people had registered for this, so I assumed that they would get an email with the slide set. How will they get access to the slides and the recording?
Yes, sorry, it's been a little bit of a mixture from some people internally registering, but what I'll do is I'm going to put everything in this chat as well. So I think then at least everyone will still have that live to access.
All right, thank you for that. Okay, let me just come back to the chat then and see what else we have. Thank you, Chris, colleague from Lancaster. Okay, slides. So, another question from Andy. Are there any requirements from GCP MHRA that should be altered to allow greener trials? That's a big question.
I've got one. Can I just go first on one? Yeah, well, it's a follow-on from the duration point that you made, Andy, because interestingly, although, as Jess said, it doesn't appear to be a hotspot now, with the introduction of the amendment to the regulations coming in April, the length of time that we're required to archive CTIMP trials is increasing from 5 years to 25 years. So that's a huge increase. If you're thinking for some of those older trials, which may have huge paper TMFs, the 25 years archiving of that is quite substantial. So that's one idea, I think.
Yeah.
And I did, yeah, go on.
Sorry. Well, I do know the other area is that is being discussed is about if you are using healthcare systems data when it comes to inspections around that and the data monitoring side of it, what are the requirements? Because the current requirements around audit trails and etc. Don't easily apply to healthcare systems data. Sorry, Lisa, I interrupted you. Did you want to say something else? Okay, all right. So I'm coming on to a question from Caroline. Rick, is there any work on different types of interventions or tests, e.g. radioactive waste or use of MRI that use resources such as helium? So in our work, Lisa, you might want to come in after this, but in our work, we have been focusing on the carbon footprint of the research processes. So things that are done because of the research. We will footprint the intervention in a trial if it is only being done as part of research, but most of the interventions that we're testing in the publicly funded arena are kind of available anyway. So we are footprinting things above and beyond what would happen routinely. There is increasing amount of work in many places, including the Lancet Med Zero, looking at environmental impact of all sorts of things, types of interventions. But if an MRI scan is part of a trial because it's an assessment of outcome perhaps or eligibility, if it's part of the research, that would be included. So I don't know, Lisa or Jess, if you want to come in. We do have emission factors for.
Yeah, no, I don't think there's anything to add. Yeah, I think at the moment we are considering the footprint of that, but understand that via all of the kind of work ongoing in the NHS, that the kind of wider LCA of those processes is probably being managed and considered outside of our work. But specifically in terms of the question of whether that, use of helium, etc., I'm not sure if that specifically is being looked at yet. I don't know, I'm afraid.
I'm moving down. Kendra Perez-Smith. The samples hotspot seemed a little low on the graph. Oh, the lab samples. Can I ask what was included? Were they low sample collecting trials? Does it include sample collection kits? I'm very big on trial samples, but thank you, Kendra. We should be talking to you more, I'm sure. Jess, did you want to come in on that? I think the sample kits were included, but.
So I think in samples, we tend to just include, within that module, we include the carbon footprint of the sample kit materials, and then also the transport of those samples to wherever they're going to be analysed or stored. And then lab is more focused on the analyses and the storage of those samples. I think you're right. I think it hasn't appeared to be a hotspot in the trials that we've footprinted. I don't think from memory any of them have done huge collections of samples. I think it's been kind of a couple at baseline, or maybe a couple throughout the trial. So I don't think we've done a trial yet that has loads and loads of samples. And I do think just some of the bigger elements, it doesn't mean that they don't have a carbon footprint and it isn't still a footprint that we should be trying to reduce. I just think sometimes the emissions attributed to things like travel and electricity of kind of the buildings used in trials kind of dwarfs those, which is why I think it's important, although we are talking about hotspots and we're talking about kind of the top 3 contributors to footprint, that doesn't mean that we shouldn't be looking at things like samples and changing whether we ship them to different countries, if we can do it within the same country, or use less plastic, or all those sorts of things. So yeah, it's a really important point. Same with kind of printing. We found that printing isn't necessarily one of the top contributors to the footprint of a trial compared to these, I guess, bigger ticket items. But again, it's something that trial staff kind of can do something about, or can try to reduce or limit the amount of printing that we do. So yeah.
And just to say, so for what we're doing, if a blood sample is being taken for routine care, but the data is being used for research, that blood sample would not be footprinted as part of the research. So it's things that are done above and beyond what would be being done as part of standard of care, which might also be a factor. But what we want to do here is to try and encourage people to footprint whilst they're at the design stage, to look at this. And so it might not be that it's the CTU emissions or the trial specific assessments, it is the lab, and then you need to look at your sampling procedures and the shipping and things. So hopefully the resources that will be appearing over in the next few months to a year in terms of things going online will be helpful to you. But in the meantime, going to Jess's drop-in clinic and using the Excel spreadsheet that we use, you can use that at the design stage. And if lab samples come out as being a hotspot, or it's a big component and you can do something about it, then obviously you should. Thanks, Jess. Let me have a look. Fiona, useful comment. Yes, indeed. So sort of like the mitigation strategies that we've talked about. This is not specific to trials. There are other types of healthcare evaluation as well. I think also the NIHR carbon reduction guidelines are being not revised, updated into environmental sustainability guidelines. So that'll be useful when they come out. Chris Hayward, it's hard to comprehend that the emissions, oh, sorry, it's jumping around. See if I can get back. Sorry. Trying to find it now. Yes, sorry, Chris. It's hard to comprehend that the emissions arising from CTU staff commuting to and working from a central office outweighs the emissions arising from site staff commuting to and working from a respectful in a multi-center.
Me too.
Okay, so the CTU emissions, Jess, or the staff travel, sorry, do you want to comment on that?
So the way that we footprint kind of people doing things in buildings, just because it's hard to actually quantify the amount of electricity being used by buildings that are being used for multiple purposes, is we take the FTE and then we multiply that by an average per FTE in that environment. And we do find that the FTE of trial staff working on a trial, like the trial management or the coordinating trial team, is generally much higher than kind of the combined FTE of site staff. So although we understand there are a lot of clinicians and nurses and consultants and things working on these trials, when you add up the total FTE, we found that I don't think I've ever come across a trial where it was, I guess, bigger than the trial staff or coordinating trial team FTE. So that's why I think it is bigger. Yeah, hope that.
But Chris, you need to remember, so we have 12 trials being shown on pie charts. We need people like you to also be looking at your trials, and we just need more data. Wouldn't want anyone to go away thinking, oh, well, let's just sort out CTU emissions, trial specific assessments, labs, and that's it, and the whole answer is digital technology. That's not what we're saying. We're literally just kind of give you a flavour of the work that's ongoing and try to offer resources to get people started and looking at this for themselves. Okay, so for some reason I'm having trouble scrolling down the chat. Let me see. We're probably over time, but let me just see. Kendra, yes, it would be great. Who's the best person to talk to? Well, Jess has put her email, or at least CICT email, further up the chat. Kendra, it'd be great if you could get in contact. We coordinate between ourselves and talk to each other a lot. So I think that's the last of the questions. There's a lot of praise for the session. So that just remains, I think. I will thank you on behalf of Lisa, Jess, and myself for attending. As I said, the Greener Trials Group is an open group within the Trials Methodology Research Partnership, and we hope to see as many of you there as possible. Thank you. Ashley, did you want to?
Just to reiterate, and thankfully there's such a vast amount in the chat, but to thank you all. That was a really interesting session, and it seems like there's a lot of actions people have already taken even during the session that I read in chat, sharing information with colleagues already. So, you know, the spread's even further. So thank you very much.